the awards. I'd like to invite the panelists up now that are going to be on our panel this afternoon, or this morning. Yeah, I guess this afternoon. And these will include Gina, Choi, and Beshoy, Yanny, both from UCLA, Adam Deising from Scripps, Tim Morgan from UCI, Zhou, who just spoke to from USC, and Annie Kardashian, who is also from USC. Thank you all for your attendance. You can take your mask off when you're speaking if you'd like. So this is open for questions from anyone. Everybody understands everything perfectly? Nora Torald.
This is sort of directed at you, Callie, but I really welcome, no, it's a question that sort of broadly applies to all of you who are dealing with sort of more advanced liver disease. So this whole question around SVR and then who should get surveillance after SVR, we see so many publications about who the high-risk group is, but actually what we really care about is who can we stop doing surveillance in. That's the issue. And so I'd really want to sort of ask you sort of, have we got any data to inform that? That's actually the sort of relevant question, I think.
Yeah, I completely agree that that's the relevant question, right? We want to stop doing ultrasounds every 6 months in perpetuity in our patients with HCV who've been cured, and there's really no other outstanding reason for potentially for following them outside of the HCC piece. I've seen a study which has looked at sort of, I think FIB4 is nice because you are able to longitudinally follow it. It's just labs. You don't have to be doing fibroscans persistently, but that's potentially another future option. But I've seen studies where if they have a persistently low FIB4, so even at baseline they had a low FIB4, they continue to have a low FIB4, that potentially in this one particular cohort, 0% went on to develop HCC. So I think people are going to start doing more studies, and I think machine learning is going to come into play as well to be able to define potentially the FIB4 over time patterns, or potentially a cutoff at FIB4, or potentially down the line using fibroscan results to determine what exactly is that threshold at which we can stop. I don't know if the other, yeah.
Yeah, I mean, I fully agree that I think we need more information. Mm-hmm. As just an anecdotal story, last year we had a gentleman who was treated for Hep C 10 plus years ago and had a cheetah SVR, who was stage F2, F3 at diagnosis back then, and when he was treated, came in with cholecystitis, and lo and behold, on imaging, had a 3.5 centimeter liver mass. Initially seen at an outside institution, so it was biopsied, and they biopsied the surrounding liver and had well-differentiated HCC, but his surrounding liver was F0 fibrosis. And so I think it really begs the question is, when do you stop? And how do you stop? And I don't know that we know that answer.
Gina, what are you guys doing at UCLA?
I think it's really hard because, like Dr. Terrell mentioned, do we practice for the exception or do we practice for what we see commonly? The guidelines say F3 and above, but of course, biopsy isn't 100% accurate, FibroScan isn't 100% accurate. How good is good enough? Especially when you have a lot of patients with comorbidities. Alcohol and Hep C are both such fibrotic diseases, and if you add NASH on top of that, or even NAFLD without NASH, how do you really risk stratify these people? And you never want to miss the exception, and we often see that in academia, but I think it's a very important question, and like everything, you need to think about your individual patient.
Yeah.
I would also say just caution using FibroScan after Hep C treatment. So, I think, the cutoffs that we use in chronic Hep C are not as reliable after treatment. We saw this in a very small group. We looked at this when I was in San Francisco, only about 20 patients, but we noted that the FibroScans post-cure really underestimated the degree of fibrosis. So I always get my FibroScans when I first see my patients before I start DAA therapy.
Yeah, Jason Pan from Oregon Unit published the same data in about 80 patients showing that FibroScan, and we actually had biopsies on 15 of them to show that they underestimated. So it's not a way off. It doesn't get you out of the deal. Tim, what are you guys doing at the VA?
We tend to use FIB4, but, you know, in listening to all of these people's response to Nora's question, I'm just even more confused. You know, you can't trust FibroScan, you know, maybe liver biopsy isn't any good. Maybe now we should be screening people that have a risk of 0.4 or 0.5 per year. And then you can't stop ever, right? Because it can pop up 10 years later. And it's a massive problem. It's a massive problem. But do I think we ought to be doing surveillance in quite a few of these people? I do. And I think you all know, getting people to do ultrasounds every 6 months is very, very difficult. I mean, nationally, it's about 50%. You're happy if it's 50% of your patients get it every 6 months.
Well, hopefully the AASLD is going to take up this issue about changing the threshold on post-SVR patients to match that threshold closer to Hep B. So the threshold for Hep B, by the way, is 0.2. So as you pointed out, it may be closer to 0.4 for post-transplant. Bob?
Great discussions, part 2 this morning. Thanks, everybody. The question I have is, we have 3 FDA-cleared biomarkers that are risk markers for HCC that are now included in the GALAD score. Are people using them? If not, why not? I've been using them for 7 years, and I have yet to have a late HCC diagnosis. Part 2, if you could address exact science, helio, methylated markers. What do we need to incorporate these new markers into our algorithm?
We haven't given the talk on HCC yet, Bob. You're way ahead of yourself.
For tomorrow.
But does somebody want to take that?
Yeah, I will say, Bob, that I am using all 3 markers. I've definitely caught people who have been negative for AFP and even having a normal L3%, but have had positive DCP.
Thank you.
I'm not routinely using all 3 for HCC screening, but if I see someone with a, you know, high AFP or liver mass, I check all 3 and go from there. But I'm curious to hear what others do.
And I'm not using all 3 as well, and I think a part of that is because of the test availability to order and insurance coverage. The availability is definitely important, and it is used in select group of patients.
Yeah, Bob, I'm not using all 3. I work at a VA hospital. But it's broader than that. I don't remember the exact numbers, but I do remember some of the numbers, and I think they were published. When we looked at the HALT-C study, which is a longitudinal study of 1,000 patients, hundreds of patients with cirrhosis, and we had 48 patients with liver cancer when we looked, not at the very end, but close to the end. Of those 48, 24, exactly half, had a completely normal AFP at the time of diagnosis of hepatocellular carcinoma. And the people also looked at, I think, DCP and AFP-L3. I don't remember. They were crappy for the diagnosis. One of them was, you know, and so I am not a super big believer. Now, you can say, well, I know, but you're going out there, you're looking for the high people, right? And when you looked at AFP, and you know, the people that come to your clinic are slightly different than the average patient out there. And you know, they get really close follow-up, both with 3 markers and probably with imaging. And that's why you're not finding big masses. But many of these people are not getting as close follow-up. And you just, and so you're gonna have people that walk in with big masses. So, you know, I'm not as strong. And when you then looked at the people with AFP over 200 and said, well, okay, well, you know what, your AFP is over 200. You know, the yield of hepatocellular carcinoma in that group was, it might have been 10%. It was relatively low. Most of them were false positives, so to speak. Now, these were mostly active Hep C, not post-treatment. And you could say, well, a 10% yield is pretty damn good. But, you know, not very many of the actual hepatocellular carcinomas had alpha proteins over 200. And 25% were entirely normal.
Thank you.
To be fair to Bob, I'm going to talk about this tomorrow, but the problem with AFP and DCP is the sensitivity sucks. The sensitivity is around 40%. Specificity is high. But the GALAD score clearly has improved that, and there was a phase 3 trial on the GALAD score that was presented at AASLD that I'm going to talk about. So that's going to change my behavior, because that got published now, and it was a lot of patients. So it's pretty compelling. It is AFP L3, AFP and DCP in a formula. So I assume that's not proprietary. Do you know that, Bob?
It's not proprietary. There is a move. Roche is trying to proprietize it, if that's a verb, I'm not sure, but they're working on it. Obviously, Fujifilm was in the front with Waco, and then Helio is including the GALAD score and those components in their methylation panel, which is, I think, 77 methylation markers. That's being looked at in the CLIMB study. There's lots going to come out on this soon. I'm going to go out on a limb and say this is what we're going to be using, this or plus methylation markers soon, for Hep C patients post-SVR, for F3 NASH patients, and then special Hep B patients, so we're not clear on who should get surveillance.
Okay, you're being recorded. We're going to play this back to you next year.
Thank you.
Yes, question.
So this question is mainly on behalf of my addiction medicine colleagues. Do we know of any biomarkers in patients when they are having alcohol use disorder that can predict that they are going to develop more severe liver disease? Because that's an important, is there any kind of signal, any kind of genetic testing, any biomarker which is available where we can say that this patient, if you continue drinking, you are going to develop that first decompensation, which we are talking about, alcohol hepatitis and severe condition?
Kim?
Come see me afterwards. We're about to publish a paper on looking at genetic markers. And I think it was mostly people that had, well, they were alcohol, it was from a prospective study that we did in an NIH-funded genetic study in alcoholic liver disease. And there were 3 or 4 genetic markers that predicted if you had all 3 of them, you had a much higher chance of going on and getting alcoholic cirrhosis. So
Is that going to be published?
It's not out there. No, it's not published yet.
Okay. Don?
Good morning. Thank you. This is, my question comes from Brian's presentation, but a general question for you. As we allocate an increasing number of livers for patients with alcohol use disorder, decompensated disease, with or without extended sobriety, do we expect a pushback in the general community in terms of donation, which is already problematic? And if so, what can we do to promote and to advocate to the general public that this is a just use of livers and an appropriate indication for liver transplant? Just be interested.
Good question. My greatest nightmare. So we'll go through each of you, because you're each at transplant centers. Beshoy, you want to go first?
Yeah, so I completely agree. This definitely poses an ethical dilemma in terms of donation, and may decrease the donor pool. But I think a big part of this is education, as we are educating ourselves as transplant hepatologists based on research and based on survival rate in patients who have heavily drank. And as we develop more predictors of survival post-transplant, I think we should make an effort to educate the donor community about those survival statistics. You know, we often hear the comparison between NASH and between alcoholic liver disease. And we say, well, patients with NASH have been told over and over again, it's very important to lose weight. It's very important to focus on lifestyle modifications. It's very important to eliminate certain types of foods. And unfortunately, those changes haven't been made, but yet you may find that there is not much of an ethical dilemma in the donor pool when a patient is getting a liver for NASH versus those who are getting a liver for alcoholic liver disease. That being said, early transplantation for patients with alcoholic liver disease should not be considered a gimme in every patient. There's a very, very highly selected group of patients. Many parties are involved in evaluating those patients very thoroughly. Psychiatry, social work, the entire transplant committee. It is definitely something that is really taken seriously by the medical community and by the transplant hepatologists and UNOS prior to allocating the livers. And I think if we make a strong effort to educate our patients and our donor pool in that regard, we may be met with less resistance.
Hallie?
Yeah, I completely agree. I think we need to destigmatize alcohol use, but at the same time educate the community about the dangers of alcohol use, because clearly these uptrends in alcohol intake and alcoholic hepatitis within the pandemic is very concerning. So I think it's that dual, make sure people understand that it's a chronic disease and it's a disease that can be treated and that needs to be treated and is undertreated and underdiagnosed, but also make sure we're starting to prevent it in clinical practice. And the second thing is I think for transplant, we need to focus our message around equity more than potentially on outcomes and sort of this new idea that, we've previously not actually had equity for these patients with alcohol use disorder and alcohol liver disease. So we're starting to actually come forward to achieve that without taking necessarily away from our other patients.
Yeah, I would totally agree. I mean, education is very key here. And my response to someone who would challenge that is that, we have been giving livers to people and transplanting people for many years who gave themselves and did things in their lives that gave themselves hepatitis B or hepatitis C, and although they may not still be, and even people who are maybe even actively using and PWIDs. So I think education is very key to, again, help destigmatize that. And to go along the lines of, how do we, assess for the risk of drinking again at post-transplant? Yes, I mean, using things like the SALT tool and all these other sort of things that we use. I think the key is a really good psychosocial evaluation pre-transplant and identifying who we think is really going to adhere after transplant. And that's the biggest thing I think we can do.
Annie, the test I use is, what if I had a family member that was donating? What if somebody died in my family? And I look at some of these inpatients that we're rounding on, and that's the test I use. Yeah. So what's going on at USC?
I mean, I agree with what everyone else has said so far. I think we need to destigmatize alcohol use and alcohol use disorder, and to also emphasize urgency in how we make decisions about who gets livers. As Beshoy said, we, in comparison to people who have NASH and gain weight after transplant and develop recurrent NASH, I think education and highlighting that outcomes are very similar post-transplant will also sort of help with educating the public, but it's certainly a risk to transplanting more patients with alcohol use disorder, that we lose donors.
I mean, I think
Gina?
we have to be stewards of these organs, and despite our attempts to kind of quantify and to predict who's going to relapse, we're not good at it, and it's because it's such a heterogeneous disease. Every person that you meet, every individual is completely different from the next, and so I think we have to have grace for ourselves, grace for our patients, but it's certainly something that keeps me up at night.
Tim, we never transplanted anybody at Rancho. Come on, man.
Pass.
Come on.
Sure, you want me to comment? No, but I
Yeah,
think it's
Tim and I both trained at the USC liver unit where we had 60 patients at all times with alcoholic liver disease, 57 with alcoholic hepatitis.
Right. Well, I think it's a great question. You have to be sure that you get the word out there. John, it's a great question. How do you make sure that you continue to get donations in face of a potential, backlash or feeling that these are going to be undeserving people? And I think education is the way you're going to have to approach this. How you're going to do the education, I don't exactly know. But it is an important issue, and I'm glad you're bringing it up.
Jeff, I think you were first, and then Buddy.
Yeah, I just have a question about ALCAP. So Brian had mentioned that the majority of patients who do survive still have an indication for transplant at 6 months, and that early death after transplant is often related to infection. So the question is, if a patient is seems like a great, if that exists, candidate for transplant who has ALCAP, should we transplant them and not bother with steroids? And the other part of the question might be, if not, should we be looking at some sort of special prophylaxis for infection prophylaxis in the patients who got steroids, either a 4-day course, a 7-day course, or 30-day course, or whatever.
Anybody want to take that?
I think the fellows have heard me say this before, but I'm terrified of steroids. I think, if you look at that study in STOPA, the average MELD in that paper was 20. And at UCLA, a lot of our patients aren't MELDs of 20, they're MELDs of 40, 35. And so I think there is a role for steroids in acute ALCAP, but trying to identify who that patient is, I think is still a challenge for many of us. I think that in terms of I think renal function is really key. I think that's really going to tell you if your patient's going to make it or not. Because if their kidneys are good, everyone's hopeful. But I don't know, that's how I feel about steroids.
We're not going to let you off the hook that easy. Just everybody gets 72 hours of, do they get a 72-hour trial of prednisone or not to see if their allele score gets better? Or do they just get listed for transplant?
Well, you just have to use the steroids correctly, right? So make sure they don't have an infection, right? And if their MELD score is 20, I think it's worth a shot. But I think often it's started inappropriately, and you get into more trouble.
Mm-hmm. Buddy, you want to comment on that, or?
No.
I know you're studying it, so.
Not on that. I didn't want to ask a question because I didn't see Brian on the panel, but since the question of transplant, I don't think you will ever get enough donors to offset the increased number of alcohol patients. Yeah. And we recently looked at this, 132,000 admissions for AH alone. And if you said 10% of them need a transplant, that takes up nearly every organ in the country. Now also, when you talk about equity, what happens to your PSC patient who has a MELD of 21 and will never get a transplant? And so I'm wondering if we need to really look at this as a separate category and say, I don't mean to stigmatize people who drink. I like to drink myself, but I really agree, and I think the way Brian presented it is absolutely true that we shouldn't stigmatize those people. But I worry a little bit about equity when we're leaving out the people who never get to that kind of MELD score and therefore will never get an organ.
Well, the other thing is Brian showed between 2014 and 16 is the number went way up. But that's, the cynical person would say that's because we cured everybody with Hep C. Mm-hmm. They were no longer listed for transplant. Julio, you're next.
Thank you. Julio Gutierrez, Scripps. I'm more skeptical that patients who get liver transplants should be expected to be absent afterwards. I mean, we see that patients who did the 6 months of abstinence before transplant, over half of those will have alcohol post-transplant. So I'm curious, especially what approaches you guys have come up with to manage your patients post-transplant to treat alcohol use disorder or to prevent it from getting out of control in your centers.
Yeah, from our standpoint, at UCLA, our psychiatrists and our social work usually recommend a plan of care post-transplant to continue getting AA, to continue seeing addiction medicine doctor, to continue seeing outpatient psychiatry. And I think the paper Dr. Lee presented earlier from Canada very eloquently talked about that. In the group of patients that were transplanted, patients, if they were capable of, they received psychosocial evaluation and support and group therapy prior to transplant, and continued the therapy post-transplant. So I believe most centers, I mean, I can speak for UCL. For us, we do recommend that patients continue with their psychosocial workup and management after liver transplantation.
I'll say at USC, I don't think we have like a formal program for these patients. Be nice. I do think it depends, obviously, a little bit on insurance and what can even be possibly covered for a lot of our more underserved patients. But I think something that we've been increasingly interested in is potentially medical treatments to maintain remission in our patients. So that's something that I think we're going to have more data on going forward, and potentially might be a good adjunct for these patients.
Yeah, I think, as you know, I think at Scripps, we try to have our patients and strongly recommend that our patients continue with the substance abuse programs, whether it be AA, whether it be the Smart Recovery, whether it be weekly psychosocial or psychotherapy, post-transplant, in those instances. And that, I think, doing that will hopefully help kind of keep them in remission.
I find also it's, helpful to understand, why they're drinking again after transplant. So is it that they're having cravings? Is it that they're, I have patients who say they're having cravings. And so if they are, then I think more about medical therapy. We do have, Dr. Hahn, one of our other hepatologists, is doing a study looking at acamprosate in our post-transplant population. So, I think about enrolling them in that study if they're complaining that, or they're telling me that they're having cravings. If it's something else, I have a patient whose mom just died and he started drinking again. So if it's, they're going through depression, they're going through something, then, ensuring that they have the appropriate psychiatric and social support from our team is the avenue that I take. And I really tell them that I want to know if they're having the cravings, if they're drinking, not just so that it's a slap on the wrist, but just so that we're able to support them through this process, and emphasize that it's a lifelong illness and that they are going to continue to struggle with, wanting to drink potentially, or, being at risk for relapse after transplant.
I think it's really important to have a plan in place, and one of my colleagues, Dr. Patel, is trying to work on that right now. But I think that I remember Mike Lucy once said that with alcohol, it's two diseases, right? One is the alcoholism and one is the liver disease. And I often feel very inequipped or ill-equipped to deal with, I'm not an addiction psychiatrist, do I get them an Uber ticket to drive them to their appointment with the psychiatrist, So I think that doesn't mean we shouldn't try, and we are trying, but I find it really, really challenging, especially with the limitations we have in our health system.
Okay.
Question, yes.
Hi. So we talked about equity of transplant. I just want to relate this topic to acute alcoholic hepatitis and how we can achieve equity of transplant for these patients, because I just want to relate two questions. One is the insurance, right? And we have perfect candidate with fit all criteria, have great family support, first offender, no psych issue before, but medical denied. And how can we overcome this equity? Even the insurance are different there. They could, the patient, how can, this is related equity of transplant. Second is if I think different centers have different criteria for transplant. And I can see, we denied from USC with some patient, no Melinda, they accept the patient for transplant. And how can we achieve this? But, we're in the same region, right? have the same donor pool. So how can we achieve, what do you think we can achieve this consensus among, like more consistent criteria to transplant these patients? So I think we can reach the fairness among transplant center to the patients, to the families, and to the other patients who are waiting for transplant.
Those are good questions. If I can rephrase them, if I may. The first is, what about insurance barriers to transplant, specifically Medi-Cal in California? And the second, what about equipoise? If for transplant programs in LA and San Diego, if Scripps says no and UCSD says yes, and how's that fair? So, Beshoy, you want to?
Yeah, so I mean, this area, just like anything in medicine, is still up and coming. So, I don't know, 100 years ago, for a heart attack, for an MI, it was take an aspirin, go rest, we'll come check on you in a little bit. And now we have come a long way placing stents and using great studies to help patients. This is, I would put this in the same category. I mean, this is up and coming. We're still learning about it. And I agree, the insurance barriers are great. Some insurance companies do not allow for this. And it's something that we go through appeal after appeal with the patient and their families, and we just have to be upfront with the patient and the families. We were trying our best. We are doctors, medically, we feel this is what needs to happen, but the barriers are X, Y, and Z. And again, informed consent and education for our patients. And I think as we learn more about this, as we show the insurance companies the outcomes, as we show the equity of the donor pool, some of the insurance companies might come around and approve some of this stuff. And in terms of transplant centers, same thing. I mean, we still just need to keep working on education, keep collecting more data, and advance in the field as we did with MIs. It's no longer an aspirin and hang out in the corner. That's what I would say.
Somebody wanted any other comments? Adam?
The insurance issue is hard, especially as you mentioned for things like Medi-Cal. And again, it's, you can try and do peer-to-peers, and sometimes they're successful, other times they're not. The last Medi-Cal one that I had a peer-to-peer with, I actually was successful in getting her listed, and she was an early ALCAP patient. And maybe he was just having a good day that day, I don't know. But it's tough. And the only thing that you can do is kind of go back to the family and say, this is unfortunately the situation that we're faced with. We can keep trying and keep pressing forward. In terms of protocols, I think for the most part, we all have very similar protocols. Now, again, things may be slightly different between institution to institution. And again, some centers may say no, while other centers may say yes. I think it is just important to let the patient know that if your center does say no, that they have potentially other options. And it's not totally unreasonable to reach out to other centers.
I see we have more questions, but I'm afraid we're out of time. So if you can ask the panelists afterwards.